I'd like to thank the Society for inviting me to give this year's GSK lecture. So it's entitled The Great Escape, My Journey in Stroke Research, and hopefully the name will become explanatory later on. So stroke is a significant cause of morbidity and mortality in the world. 1 in 6 people will have a stroke in their lifetime. We still use the traditional older definition of a clinical stroke as a clinical syndrome characterized by rapidly developing clinical symptoms and signs of focal and at times global loss of cerebral function with symptoms lasting more than 24 hours and leading to death. The important thing is it's a vascular cause. So stroke is a vascular condition in the majority of cases. There are newer definitions which include imaging definitions of stroke with advances in MRI scanning, but we still use this traditional clinical definition of stroke. Causes of ischemic stroke, 80% of stroke are ischemic in origin, either caused by a narrowing of the carotid or vertebral artery, cardioembolism, or small vessel disease from chronic atherosclerosis. 20% of stroke tend to be hemorrhagic due to either an AV malformation, a weakening of the diseased blood vessels which rupture, usually due to uncontrolled hypertension. But this is a lesser form of stroke, cause of stroke, and most of my talk today will be devoted to the treatment of ischemic stroke. Stroke is the third leading cause of loss of life in the world. It has fallen from being the second leading cause of death, but it's now the third leading cause of death, and is significant, as I mentioned, cause of morbidity and mortality in the world. However, mortality is falling, and this is likely due to the increased aggressive management of secondary causes of stroke, such as management of hyperlipidemia, diabetes, hypertension. So we're addressing the risk factors for stroke better. So mortality is actually falling. However, there is a demographic transition that's going on in the world at the moment. These were the projected figures in the United Kingdom for our population in 2000. And you can see how it's changed to the projected figures in 2050. So there's a larger number of patients surviving into their 60s, 70s, and 80s, and hence the prevalence of stroke will be increasing. So whilst the incidence is falling, the prevalence of stroke disease is increasing. So there's more patients that we're going to have to treat with stroke. And it's been a similar pattern that we've seen in Ireland. A large increase is projected in the older age groups in Ireland over the next 10 years. Now, in terms of the management of stroke, we talk about the stroke chain of survival. And this starts at rapid detection of early warning symptoms and signs of stroke, to rapid paramedical pre-hospital care, rapid transport and pre-alert, rapid hospital diagnosis and treatment, and then rehabilitation, surgery, and tertiary referral in some cases. It's all about time, though, in stroke. And there's been a number of campaigns that have been applied throughout the world regarding the recognition of the signs and symptoms of stroke. And indeed, in America, they use these education programs in schools to educate children about the signs and symptoms of stroke so that they can recognize them in either their parents or their grandparents. And this is the example of the FAST campaign that was introduced in Ireland.
The damage spreads like a fire in the brain. To spot the signs of a stroke, you have to think and act fast. F. Face. Has the face fallen on one side? Can they smile? A. Arms. Can they raise both arms and keep them there? S. Speech. Is their speech slurred? T. Time. Just like a fire, it's time to call 999 if you see any single one of these signs. The faster you act, the more of the person you save. When stroke strikes, act fast.
So in Ireland, we had one campaign, one educational campaign, and we did a study around that campaign in our local hospitals. And we found that around the time of the campaign, there was nearly a 60% increase in presentations to the Accident and Emergency Department within 3 hours during the actual campaign. But unfortunately, what happened is that the figures fell and returned to the pre-campaign figures 2 weeks after the campaign had been completed. So these educational campaigns are important. They need to be reinforced so that patients can present early for treatment, because the treatment is time dependent. So we had to resort, unfortunately, we have our FAST campaign is on ambulances now, but we don't have a traditional educational program through the media, and this is so important in terms of the identification of patients with stroke. So we've done a number of papers, written a number of papers around this whole issue, and more recently we've actually identified that even within hospital departments there's a different appreciation about the management of stroke, and it can vary, that if you're in an orthopedic department, in a medical department or a neurology department, your time to get treated for stroke can vary. So the history of stroke, if you were starting medicine in 1983, you would have been told that there was little that we could offer for patients with stroke. And I still remember the times when we used to do ward rounds, and the patient who'd suffered a stroke was often the last patient that would be seen, because there was a sense of that we couldn't do anything for these patients. And indeed, at the time, if you read the Oxford textbook of medicine, they would have said that there was little that we could offer, and that there was a concern that even antifibrinolytic agents could have been, fibrinolytic agents could be harmful. But then we had the evidence developing in the early 1990s for stroke units, carotid endarterectomy in patients with symptomatic carotid artery disease, aspirin in 1997 from the IST study, which was shown to prevent early recurrent stroke. Alteplase was then licensed, and this was a key game changer in the management of acute stroke, and it was recommended by NICE in 2007 for thrombolysis in acute ischemic stroke. We then went on and developed outpatient services, early supported discharges, hemicraniectomy for those small amount of patients who require this treatment in malignant MCA syndrome. And then we've had more recently the development of newer anticoagulants for patients with atrial fibrillation. Now, warfarin is still a very good agent and has been shown to be efficacious in patients with atrial fibrillation in terms of preventing stroke. And these were the earlier figures, the earlier studies with warfarin, which shown it to be a safe and effective agent. But we do have problems with the use of warfarin in anticoagulation, and in terms of stroke. If we have under anticoagulation, we have here a patient who suffered an ischemic stroke as a result of under anticoagulation with warfarin. And then there's the opposite in terms of over anticoagulation, leading to an intracerebral hemorrhage. So it's not ideal, and as I mentioned, there's newer anticoagulants that have come to the fore with dabigatran, edoxabam, and rivaroxaban, and apixaban. And more recently, you may be aware that there's also an antidote to dabigatran. So these anticoagulants, they do have their advantages and their disadvantages. Their advantages being that they have an immediate onset of action, they have absence or lower incidence of interactions, they maybe provide greater convenience for patients. They may be more cost effective if we take into account the cost of warfarin clinics. However, they do have some disadvantages in that they still require monitoring of renal function. There's a limited availability of assays for measuring their levels. There's a potential for overuse in an unlicensed way. They have higher acquisition costs. Short half-life, which means that if a patient misses the dose, there may be a risk of them being under anticoagulated. And there's no specific antidotes to these agents except for dabigatran in the case of major bleeding. And 2 weeks ago, this drug, which I will not try to pronounce this afternoon, became available as an antidote for dabigatran therapies. It's a specific monoclonal antibody which works specifically on the binding site for dabigatran, has a binding affinity of over 350 times higher than the anticoagulant dabigatran. So we've had some successes in terms of secondary prevention and development of treatments, but we've had some failures as well. And we've struggled with the calcium channel antagonists, neutrophil inhibitors, GABA enhancers, and nitrones, and neuroprotectives. The more recent one was NXY059, which is an antioxidant used for, which was developed for acute ischemic stroke. And unfortunately, as a result of the SAINT-1 study, this agent was not found to be efficacious. And I suppose highlighted here by the share price of the company that developed it, going rapidly up and then rapidly down, unfortunately. So we've had our successes and we've had our failures in stroke research. And stroke research, I think, illustrates the translational medicine continuum very well, going from bench to bedside, from bedside to community, and from community to policy. So I hope that I'll be able to explain this more throughout this lecture. So in terms of looking at bench to bedside, we talked earlier about the advances that aspirin initially in 1997 had shown, and indeed platelets do have a strong role to play in stroke in terms of development of atherosclerosis, arterial thrombosis, and also in the development of embolism from artery to artery. And in 1997, the IST-2 study suggested that aspirin would produce a small but real reduction of about 10 deaths or recurrent strokes per 100. So very marginal benefit, but still enough to have aspirin in the guidelines for secondary prevention following stroke. However, there has been a significant debate about this whole term around Aspen failure or Aspen resistance and the reasons for this in subsets of patients. And this could be to do with the dose and bioavailability of the aspirin preparation. It could be due to genetic differences, metabolic differences in platelets, interactions with other drugs, other platelet factors, and perhaps the old hobby horse of clinical pharmacologists, non-compliance and non-adherence. And indeed, if you look at a number of studies that have identified aspirin resistance, and aspirin resistance is a very loose term because of the different assays that were used in these studies, there is a tendency for increased cardiovascular risk in patients who do have aspirin resistance. And in the field of stroke, again, there's a number of papers that are published which suggest that aspirin resistance may be as prevalent as between 10 and up to 70% in some cases. Again, it depends on the assay that you're using, and there's a lot of controversy around those assays that were used. And more recently, there's been an association found between carriage of the P1A2 allele and the increased risk of stroke. So there is something in the story around platelets and their reactivity, and a certain subset of patients may not benefit from standard antiplatelet therapy. So we did in Aberdeen a study of a small group of patients being admitted to the stroke unit who were already on aspirin. We tested their platelet activity through a series of aggregation tests, and then we gave them aspirin again after 48 hours when they were on the stroke unit to see if they responded to aspirin. And what we found was that there was an incomplete response to aspirin in 43% of patients admitted to the stroke unit who were already on aspirin, but that 50% of the non-response that we found was actually accounted for by non-adherence. So when we gave them aspirin again, they tended to respond. So again, non-adherence is a significant issue, I think, in the whole story around aspirin resistance. Around this time, there was also concern about removing antiplatelet therapy from patients who had been on them for long periods of time. So patients who may have been on a combination of aspirin and clopidogrel for coronary artery disease. And there was a number of reports that have suggested that when clopidogrel was withdrawn, that patients had an increased risk of cardiac events. So as we know, clopidogrel is an antiplatelet agent. It blocks the P2Y12 ADP receptors, and aggregation and activation is inhibited for the whole lifetime of the platelet. There were reports of increased ischemic and thrombotic events following planned cessation of clopidogrel therapy. And this raised the possibility of a rebound effect. So we wanted to look into this with my colleagues Isabel Ford in Aberdeen, and we did a randomized controlled study of platelet activity before and after cessation of clopidogrel therapy in patients with stable cardiovascular disease. And the research question is, could increased thrombotic events be due to the production of hyperreactive platelets? In other words, could there be a rebound in platelet activity be identified? And the aim of the study was to determine if withdrawal of clopidogrel therapy could lead to increased platelet activity compared to pre-treatment values in patients with established coronary artery disease or peripheral artery disease. So we had 171 patients randomized into this double-blind placebo-controlled study. They were already taking aspirin and a statin. We allocated them to treatment for 30 days to 75 milligrams of clopidogrel or placebo, and we minimized them to balance age, gender, and smoking status. And then we measured their platelet function on day 7, 14, and 28 days following a cessation of clopidogrel. And as you can see, with the primary outcome, there was no evidence of any rebound in platelet activity on the number of platelet tests that we used. Again, they stayed very broad, and you can see here, this is just is evidence that the clopidogrel was working in these patients. So the models confirmed that there was no statistically significant differences overall between the clopidogrel and the placebo group, with no evidence of an interaction between platelet inhibition over time and treatment allocation, and no evidence of a rebound effect. And at the time, this was the first RCT to show that to extensively assess platelet activation and aggregation before as well as after clopidogrel therapy. And we didn't find any evidence of a rebound effect in platelet activity to above baseline after stopping clopidogrel, which provided some reassurance that this drug could be stopped safely in patients with established and stable coronary artery disease or peripheral vascular disease, and those patients who were already taking aspirin. So to move now back to the acute management of stroke. As a stroke physician, what we're trying to aim at is to have the smallest amount of brain tissue infarcted. So in other words, with treatment, we hope to have a small area of infarction or dead tissue. And this is the consequence of untreated or late treatments. So the NIN study in the early 1996 showed that there was benefit for thrombolysis in a time-dependent manner in patients with acute ischemic stroke. And it's interesting to know that the typical patient loses nearly 2 million neurons each minute in which a stroke is untreated. And that's useful when we're trying to bring the patient from the accident emergency department to the radiology department, and we're trying to reduce time. We always tell the porters and the staff to say we're losing another 2 million brain cells. So it tends to move things along quite quickly. And again, this was the seminal paper which showed the benefit of thrombolysis. And Charles Wardlaw wrote an interesting commentary 5 years later to say that this was one of the papers that really does get doctors out of their beds to come in and treat patients. This was again an important landmark in the acute management of stroke. And there is a strong relationship between the start of stroke onset, the timing of it, and the start of treatment with functional outcome. We lose benefit for every 90 minutes that we don't treat an ischemic stroke. And that's very important. Whilst it is important that we treat patients within the time scale of 4.5 hours at the moment with thrombolysis, the earlier we treat patients, the better the outcome, the better the overall outcome for that patient. So ideally what happens, our patient suffers a stroke, we ring 999, they go and are brought in by an ambulance to the accident emergency department, a rapid assessment of their signs and symptoms, they have an urgent CT scan to outrule intracerebral hemorrhage, and if they have no contraindications, they receive thrombolysis, and hopefully there's a favourable outcome and they do very well. Now, that's the standard model, but then there's the German model, and the German model is even more efficacious, because what they do is, in some cases, they have a CT scanner in the ambulance, and the ambulance goes out to the patient in their home, does the CT scan, and then delivers thrombolysis in the field. And again, this is more efficacious. It reduces time to treatment and time to symptom onset, and all of the times that we want to treat patients are all reduced in this group. So again, it just illustrates the importance of getting the patient to the medical practitioner to get the diagnosis and the treatment as fast as possible. We've also had the opportunity to look at newer thrombolytics, and there's some evidence to suggest that tenecteplase may be a more thrombin-specific thrombolytic agent, which may provide a slightly better advantage over TPA. So we may be able to develop more specific agents, which again can improve outcome for our patients. But one of the issues that we always harp back to in terms of acute stroke management is recanalization of these arteries that are blocked. And here's a scenario on the left where you've got a blocked middle cerebral artery with thrombus, and you want to break that thrombus up and save infarcted tissue. So the aim is to recanalize that blood vessel. And TPA or thrombolysis at best will probably recanalize that vessel in 40% of cases. And the earlier studies of clot retrieval, in other words, where you go and actually remove these clots, they showed that there was better recanalization rates. But the problem was that these were not associated with a better clinical outcome. So we had the PROACT study, the MERCY study, the multi-MERCY study, and the Penumbra. All of these studies showed very favorable recanalization rates when patients had their CT angiograms done, but the patients didn't do better. So there needed to be an improvement in the way that we could recanalize patients with stroke and improve patient outcome. So this is what thrombectomy is all about, and this is a short video which illustrates a thrombectomy procedure. So a catheter is passed up through the femoral artery, up into the internal carotid artery. It goes through the clot, which is causing here, in this case, an occlusion of the middle cerebral artery. A sheet is then passed through it. And then what we call a stent retriever. And there's been a huge advance in the technology in this field in terms of the different types of stent retrievers that have been developed. And what they do is they literally catch the clot and remove it. So it seems a very simple procedure, but it's not. This is a very technical, highly specialized procedure that's usually performed by a neuroradiologist. And here's a CT angiogram which shows an occlusion of a right middle cerebral artery in a patient who underwent a thrombectomy. And this is the size of a clot that's removed from a patient who's had such a procedure. It's nearly 2 centimeters long, and that was in the middle cerebral artery of a patient. So these are significant clot burdens, and you can imagine how difficult it may be to lyse that in terms of thrombolysis. So in Beaumont, in our hospital, we were providing a thrombectomy service from approximately 2010 up until 2014, 2015 as well. We were increasing our numbers. We were auditing our results. We had done up until 2013 approximately 120 cases. The overall outcome was favorable compared with patients who revascularized. So the patients who got revascularization did better than those who didn't, as you would expect. The safety was on a par with other studies at the time. We were doing these in individual cases on a case-by-case basis, and really developing the expertise in our centre, which also has neurosurgical support. So then 3 studies were published in a simultaneous journal, in a simultaneous manner in the New England Journal of Medicine in 2011, which suggested that there may be equipoise around thrombectomy. And these 3 studies, whilst they had their advantages and disadvantages in terms of methodology, had suggested that there was little difference between thrombectomy and best medical treatment. So at that time, then we had to make a decision about the thrombectomy service that we were providing at Beaumont. And we decided that we would then randomise, or we would get involved in a randomised controlled study. Like every clinical question we have in medicine, if there's clinical equipoise, the answer is to randomise the patient. So ESCAPE, it's a long-winded name for this. It's endovascular treatment of small core and anterior circulation proximal occlusion with emphasis on minimizing CT to recanalization times. So hence you can understand why it was called ESCAPE. And I'm presenting this on behalf of my co-lead in Ireland, John Thornton, and on behalf of the ESCAPE trial investigators. So the conception that we had around ESCAPE was this patient who suffered a large vessel occlusion stroke, do we take them to the endovascular suite for thrombectomy? And we wanted to have sequential patient randomization, fast and simple imaging paradigm, quick workflow, parallel processing, and effective technology and technique to get good reperfusion. These are radiological scores of reperfusion called the TICI score. And our inclusion criteria was acute ischemic stroke with a significant disability, an NIHSS scale greater than 5. We randomized patients up until 12 hours from the onset of symptoms. There was no upper age limit. There was good functional status in our patients. And we did a CT scan which showed no evidence of significant infarction. We also did a CT angiogram on all our patients which confirmed large vessel occlusion. And we also were able to look at the collaterals of these patients post the area of occlusion. And again, these give us good information on how well these patients will do. If they've got good collaterals, these patients tend to do better from the procedure. So there were 22 centres led out of Canada from Michael Hill and his group, and there was one centre in Ireland in Beaumont. TPA thrombolysis was given to patients who were eligible. Imaging had to show a small core proximal intracranial artery occlusion with moderate to good collaterals on CT angiogram, and we had an intensive quality improvement programme throughout this whole study with personalised site visits from the investigators. So we were able to randomise patients from the entire island of Ireland at the time. We randomised 34 patients into this trial. We were the largest recruiting centre outside of Canada, and our fastest transfer time from Letterkenny, which is here up in the north of the northwest of Ireland, was 2.5 hours by ambulance on the road to get to Beaumont for randomisation, which is quite impressive. So we did, all patients before they were randomized needed to have a non-contrast CT scan, and basically we looked at the aspect score, and this aspect score looks at areas of infarction, and a mark of 1 is taken away for every area of infarction. So it's marked out of 10, so the lower the score, the more infarction has occurred already in the brain, and the lower the score, the poorer the outcome for the patient, and also they wouldn't be eligible for the study if their aspect score was less than 5. So here's a patient who's got a normal CT brain scan in the left hemisphere, and their aspect score is 10, and this patient would be eligible for enrolment into ESCAPE. In comparison, this is a patient who's, you may be familiar with the term an acute middle cerebral artery occlusion, an MCA sign here, and they've got extensive infarction on the right hemisphere showing, and their aspect score is 0. They've got extensive infarction. They're not going to benefit from reperfusion or even from thrombolysis. We did CT angiogram again, which showed, which was important to confirm that the patient had a large vessel that had occluded and that could be amenable to thrombectomy. And these are the various sequences that we went through in the radiological sequences. We also were able to look at collaterals post occlusion to see if these patients had good collaterals in the cerebral circulation to determine if they would be eligible for ESCAPE. So we randomized patients of standard against standard of care versus standard of care and endovascular treatment. We had very specific and tight time targets with CT from head to groin puncture of 60 minutes, from CT head to first recanalization of 90 minutes. So these are quite ambitious time targets, and we achieved these in the majority of our patients. We were able to, use of retrievable stents were recommended, and we avoided use of general anesthesia. So again, the literature would suggest that patients who require general anesthesia have a less favourable outcome. So the study was going well. We had hoped to randomize 500 patients to the study. And then in August or October 2011, the Mr. Clean results were presented at the World Stroke Conference. And the trial steering committee had to suspend recruitment into the study because we had deferred consent for this patient. So patients were randomized into the study and then consent was taken after the randomization process because it was an acute intervention study. So because there was another study that showed some benefit for thrombectomy, we needed to stop escape at the time. The planned interim analysis was conducted several weeks early, and the trial was then halted at the recommendation of the DSMB because of the efficacy boundary had been crossed, and that was in November 2014. These were the baseline characteristics of the patients who were recruited into ESCAPE. There was good match between the intervention and the control groups in terms of risk factors for stroke. Again, the treatment time intervals were quite ambitious, but we got the majority of our patients from CT to groin puncture of 51 minutes and CT to first V perfusion of 84 minutes. And this was the first thrombectomy study which actually showed an improvement in mortality. The Mr. Clean study had shown an improvement in terms of functional outcome, but we had shown a 9% reduction in rate of death compared with the control group. And the outcomes in terms of disability and in terms of stroke medicine, disability, we always aim for a modified Rankin scale of less than or equal to 2. An MRS of between 0 and 2 at 90 days is the general outcome that we use in terms of stroke studies. So 53% reached that in the intervention group as opposed to 29% in the control group. And again, they had a favourable outcome in terms of other disability scores, in terms of the NIHSS and quality of life questionnaire as well. We looked at the modified Rankin scale, and again, this is a disability score. So from 0 to 6, a modified Rankin of 6 is death, as opposed to 1, which is completely independent. And we showed that compared with the control and the intervention, there was less people disabled compared with the control group across the overall ESCAPE trial results. And in the patients who received IVTPA, and about 70% of patients in the control and the intervention group received thrombolysis. Again, there was a favourable outcome in terms of the intervention group. And there was a group of patients who didn't get IVTPA, and again, they benefited from the intervention group compared with the control group. And we showed benefit across all the subgroup analysis, but there was no heterogeneity of effect across all the subgroups. So the effect size for the intervention was a common odds ratio of 3.1 with a number needed to treat of 4. Another way of putting our ESCAPE outcomes, we could see here that in terms of medical treatment, endovascular treatment caused we had a higher group of patients who had a positive outcome, less who were disabled, and less who died as a result of endovascular treatment. So our conclusion from ESCAPE was that it was a safe, highly effective procedure, and this is important. It does save lives and dramatically reduces disability when these criteria are employed. When patients are carefully selected by imaging to identify proximal occlusions and exclude large core and exclude patients with absent collaterals, and when treatment is delivered in a safe and effective way and fast, and using a safe, effective technology. So a bit like when we wait for buses, they all tend to come along together. There were 5 studies then published in the same, very shortly after each other, which again showed a benefit for thrombectomy as opposed to standard medical treatment in acute ischemic stroke. And these are the 5 studies. Mr. Clean was the first one, followed by ESCAPE, Extend IA, Swift Prime, and ReVasCART. And they all had slightly different methodologies and recruitment criteria. But if you look at the number needed to treat on the bottom, and I know it's a small you can see that the number needed to treat ranges from 3.2 to 7.4. So this is a very highly effective treatment for these patients if they're carefully selected. And if we look at NNTs in context, you can see that for stroke thrombolysis, the NNT is 6. For cardiac revascularization, it's 18. For stroke unit care is 20. So these are very favourable number needed to treat figures for our patients. Now, I'm going to move again along the translational medicine continuum from bedside to community. And we've just completed a study called Aspire-S, and this was the premise of this study was to see if patients who've already suffered a stroke could get the appropriate treatment in the community. Because we have all the study evidence that shows that antiplatelet therapy, statin therapy, blood pressure management, anticoagulation in patients with atrial fibrillation is all effective for patients with stroke. So we want to see if patients are receiving these appropriate treatments in the community. So this was a prospective study. Patients were being followed up 6 months after their ischemic stroke, and we wanted to profile these patients to see if they received appropriate secondary preventive measurements and therapies. We followed up over 256 patients at 6 months. They had a range of risk factors at baseline for stroke disease. And these were the lipid profile at 6 months, which showed that we haven't got very tight control of lipid total cholesterol, and we used 2 different targets, at total cholesterol of less than 5 or 4.5. So we weren't getting all patients to target 6 months after their ischemic stroke. And similarly, blood pressure was not being well controlled. We used different targets for these patients with blood pressure. We used the European hypertension guidelines, the stroke local guidelines, and again, even if we used tight control, looser control, patients were not getting to target in these categories. Only 16% of patients had their blood pressure less than 130/80. 36% of patients less than 140/90. So we're not good at secondary prevention of patients with stroke either. And again, we had a subgroup of patients, we haven't published these yet, but these are patients who also had 24-hour blood pressure monitoring done at the time. These showed slightly better results because ABPM is often a little bit better at assessing blood pressure control. But again, a significant amount of patients who suffered a stroke didn't have good blood pressure control at 6 months. And we compared these figures with the cardiac equivalent, which was the Eurospire findings, and these again showed slightly better in terms of we might be better at secondary prevention of stroke compared with cardiovascular disease. But again, they're not very impressive figures and would echo the problems that we have in cardiovascular disease as well. So our conclusions from Aspire-S was that 68% of patients had a high BMI. They were still smoking. 6.4% were still smoking. 63% of patients, again, had poor control of their blood pressure. 23% of patients had poor cholesterol control. And of our diabetic patients, which we looked at separately, again, based on the HbA1c, 28% had poor control of their diabetes. Interestingly enough, when we looked at patients who had atrial fibrillation, 82% of patients were taking anticoagulant therapy, and at one time point, at 6 months, they were within the target range for their warfarin control. The other part of looking at translating the benefits of clinical trials into large populations is to look at inequalities. And at an early stage, when we were looking at prescribing practices in Ireland, we were looking to see if there was any inequalities in the management of ischemic heart disease and stroke. And there's evidence to suggest in the literature that there is an inequality, certainly between men and women, regarding the treatment of cardiovascular disease. Women tend to experience chest pain as their chief symptoms, but then are referred less for invasive investigations of their coronary artery disease. And we know again that secondary prevention of coronary artery disease includes beta blockers, statin therapy, good blood pressure control. And nitrate prescribing has been shown to be a useful surrogate for patients with CHD with a relatively good sensitivity in prescription databases and a good specificity for patients with coronary artery disease or ischemic heart disease. So we wanted to see if the Yentl Syndrome pertains in the general population. You probably are familiar with the film Yentl, where the character of the film has to dress up as a male to receive an equivalent education. And this has been mentioned in the literature, in the medical literature in cardiovascular disease. So what we found when we interrogated the prescription database in Ireland was that we found that women were less likely who had been prescribed a nitrate to be prescribed a beta blocker, calcium channel antagonist, statin or warfarin. However, they were more likely to be prescribed benzodiazepines, antidepressants, and non-steroidal anti-inflammatory drugs, which we thought was quite interesting. But again, it suggests that there is an inequality in the management of ischemic heart disease in the general population. We looked at a similar question of stroke management when I was working in Scotland using another prescription database. And what we found was that women with stroke were less likely to receive ACE inhibitors, antiplatelet therapies, and were less likely to receive anticoagulation for atrial fibrillation. So these inequalities happen, and they need to be explored, and I suppose they show the benefit of interrogating large prescription databases and health databases to see if these inequalities exist and put in strategies to improve them or to reduce the inequalities. So, again in 2005, we wanted to see the effect of the GP contract. The GP contract was introduced into Scotland at the time, and it was based on financial incentives. So we wanted to see if these financial incentives could improve these inequalities and could they improve the management of patients with stroke. And perhaps not unsurprisingly, that the incentive-based contract to GPs at the time increased the documentation of the various quality indicators. And these quality indicators would include measurement of blood pressure, anticoagulation of patients with atrial fibrillation. So this is perhaps one way that we can improve the management of the wider population, financial incentives. However, we still found that women were less likely to have their smoking habits recorded and also to receive antiplatelet or anticoagulant therapy. So these inequalities still existed. So finally, to look at the last part of the translational medicine continuum, moving from the community to policy. And I think this is an important part that clinical pharmacology can now play. So for this patient who wants to find out which is the drug that cures the headache and causes stroke, or is it the one that eases the pain but causes the heart attack, it's important that clinical pharmacologists provide those answers for our patients. So if we look at the advances that we've had in stroke care, I mentioned these earlier on, 2015 is probably going to be the time of coming of age for thrombectomy for acute ischemic stroke. Indeed, the recent Lancet Neurology editorial last week wrote an editorial on this whole particular topic in terms of stroke in 2015 and the year of endovascular treatment. There are guidelines out there now in terms of how we manage patients with acute stroke, and this is going to be a huge problem or issue in terms of management of patients with acute ischemic stroke. How do we provide this service to all of our populations? How are we going to employ neuroradiologists to provide this service? How are we going to get patients to centres to provide this service? And this is going to, this is a huge issue at the moment in terms of the delivery of service. And perhaps even a bigger issue in terms of stroke is that while stroke is the second most leading cause of death in the UK, our patients, in terms of research that's spent on stroke patients, is only 69 pence per person per year compared to other illnesses. Now, and the British Pharmacological Society has written two important papers and reports on the role of clinical pharmacology in the NHS, and has identified a number of priorities to deliver the future ambitions of clinical pharmacology. And these include around the workforce, around productivity and efficacy, around medicines management and innovation, and around patient safety. And I think clinical pharmacology has a strong role to play in the field of patient safety. And we've just completed the first Irish National Adverse Event Study in Ireland, which we hope to report on in early January, which looks at patient safety and adverse events in hospitals. And again, this is another role that I think the clinical pharmacologists can play a role in and lead on. So in conclusion, I think stroke medicine provides a model for the continuum of translational medicine. Clinical pharmacology is well positioned to exert a greater influence on public policy through this community to policy part of the translational medicine continuum. Thrombectomy, I believe, will become the standard of care for large vessel occlusive stroke, and clinical pharmacology will continue to play an important role in patient safety. And finally, I'd like to acknowledge all of my research collaborators over the last number of years in Dublin and in Aberdeen and in Canada. This work could not have been done without their help and support. And I'd like to thank you again for your attention this afternoon.